So let's talk about elimination. Elimination is the act of getting rid of waste product, whether it be urine or feces. So this has to do with your urinary system and your digestive system. So we'll start with urinary system first. So urine is the byproduct of what your kidneys filter your blood from. So it has all types of waste products in it, and that mixes with water to form urine. So the kidneys filter it, it moves through the ureters into the bladder where it's stored until it's eliminated down the urethra. A person typically urinates about 1,500 milliliters a day. Of course, this is going to be different for everybody. If you're drinking a lot of water, you may be urinating more than 1,500 milliliters a day. Or if you're dehydrated, it might be less. Some people have kidney failure and they actually don't have the ability to urinate at all, so they'd have no urinary output. For a normal person, the urine should be pale yellow to amber in color. You don't want it to be very, very dark because then it's too concentrated. It might mean that the person's dehydrated. And if it's clear, then it might mean that they're oversaturated. They're getting too much fluid. It should also be pretty clear, so you should be able to see through it. You don't want any particles floating around in there, or mucus or blood or pus, and it shouldn't be cloudy. If you see any of those things, that's something that you would need to report to the nurse right away. So some of the disorders that we associate with the urinary system, some of them we talked about already. But if somebody is complaining of burning or polyuria, where they're constantly going and peeing, or they're peeing small amounts, that could be an indication of a UTI. And if you've had a UTI, you know exactly what that feels like. It's pretty miserable. Another word for a UTI is a bladder infection. That's the layman's term for it. Or cystitis. So if you hear cystitis, that means a urinary tract infection. And if it gets serious enough, it can move to the kidneys, and that would be a kidney infection or a nephritis. And if the person has that, they are usually very, very sick. They have very high fevers, and they're just completely miserable. And it can lead to kidney failure, so it can become a pretty big problem. There are different types of incontinence, too. And incontinence just means that the person's not able to control the flow of urine, so they end up urinating on themselves. They may have stress incontinence. That's pretty common in women, especially after childbearing. You cough, sneeze, laugh, and you end up urinating a little bit on yourself. Urge incontinence is when you feel the urge to urinate, but you're not actually able to make it to the bathroom in time. So you feel the urge and immediately start urinating. Overflow is when the bladder becomes so full that it just starts overflowing, right? Just like a full cup of water. A functional incontinence means that person may be able to use the bathroom and be continent, but they can't physically make it to the bathroom. So they end up being incontinent because they can't walk to the bathroom for whatever reason. And then reflex incontinence may also be called like neurogenic incontinence, or you may have heard the term neurogenic bladder, where the nerves are damaged and they don't have that sensation when the bladder is full. So when the bladder is full, they just end up urinating. Sometimes people who have that have to be catheterized so that their bladder gets fully emptied and they don't end up getting a UTI from all that urine just sitting in the bladder or becoming too full and causing stress on the body. So there are things that we use. We've gone over bedside commodes. They sit next to the bed, and that's for somebody who maybe can't make it all the way to the bathroom, but maybe they can make it just to the edge of the bed and use the bathroom there. We also use bedpans, so that is one of your skills, is to put somebody on a bedpan, so make sure that you review that. And then urinals, usually for men. They do make female urinals, but they're not ideal, so usually a urinal is just for a man. And then briefs. Sometimes if people are incontinent, they like to wear briefs. Please don't call these diapers, because we're dealing with adults here, and adults do not wear diapers. They wear briefs. So even in a facility, you're going to say the word brief. They may say diaper, but you're going to say brief. Okay? So we'll go over the proper way to apply a brief and to take it off, because if you're working in long-term care, that's something that you do pretty frequently. And then urinary catheters. This isn't something that we use very frequently anymore. We used to use them a lot more, but this is a plastic catheter, and it's introduced into the bladder through the urethra. So this is not a skill that you learn in this class, how to put catheters in, but it is something that you learn in your first semester of nursing school, typically. So this will go through the urethra into the bladder, and then once it's in there, it's held in place by a balloon. So we would insert the catheter and then inflate the balloon. The little balloon inflates, and it kind of anchors it in the bladder. So hopefully it doesn't fall out. These can be dangerous though, because like I said, this is a sterile environment, and now you have this nice little highway to go up into the bladder and cause an infection. But this can also get ripped out. If there's a lot of tugging going on, if this isn't properly secured to their thigh the way that it should be, it can rip through the urethra, and it can cause a lot of damage and a lot of pain. Especially for men when they have enlarged prostates, and you have that full balloon ripping through the urethra right around that tender prostate tissue. It starts to swell up, and it can actually close off that urethra to the point where they're not able to urinate, and then you've got a major problem. So we only use these if it's absolutely necessary. So some of the circumstances when we may use them is if the person's very, very sick and they're in septic shock, and we need to know exactly how much they're urinating for kidney function. And then we also have a probe sometimes on here that has a temperature gauge on it, so we can get their core temperature as well as getting their urinary output. We may use it if somebody's getting an epidural. They can't feel that they need to urinate, so they may need that. If they're going to surgery, they may get a catheter temporarily. Sometimes if people do have that neurogenic bladder, they may have to self-catheterize themselves. They usually do that several times a day in that case, and with that type of catheter does not have the balloon on the end, because it's just going in and going right back out. So this would be called an indwelling catheter with the balloon on the end, because it's staying in. And then if we need a urine specimen on somebody who is incontinent and we have to have it, then we may have to do a straight cath just to get that urine specimen, and then it comes right back out. But like I said, this is a sterile procedure, so this is not within your scope of practice to do. If you know that somebody's having it done, though, you should ask if you can watch the procedure being done, just so you see how it's being done. So once this catheter is in place, if it's an indwelling catheter, the end of it is going to be attached to a bag, so the urine can collect in there. And there's a picture up here of a drainage bag. That is an ugly color. Hopefully that your urine's not going to look like that. I'm not sure what's going on with that person. But if they do have an indwelling catheter with this urinary drainage bag, it has to be emptied at least once a shift, or whenever it starts getting full, because you do not want this thing to burst on you. It could also cause back into the bladder, so that would cause a problem, right? If urine's going back into the bladder, that's definitely going to possibly cause an infection. You want to make sure there's no kinks in that tubing. You want to make sure they're not laying on it, that it's not tugging at all. And you want to make sure that the urinary drainage bag is attached to the bed frame and not a bed rail, because this cannot move around anywhere. That's very important, because we don't want to be responsible for that thing ripping out and causing damage to our resident or our patient. So that will be your responsibility. And then for the digestive system, of course, we have our byproduct of waste is feces or stool or poop. All the same thing. So food is broken down in the stomach, and the stomach churns it up, turns it into chyme, and then it moves through the intestines, where the intestines soak up nutrients and water, and whatever is left over becomes feces. Feces should be brown, it should be soft, and it should be formed. It shouldn't be rock hard, it shouldn't be watery, it shouldn't be red or black or white. Okay, if you see any of those things, then you need to tell the nurse right away, because that's a problem. That means there's something wrong with this person. And we can learn a lot from what somebody's feces looks like. And it should be about the shape of the colon. We don't want little rabbit poops, that are real small or really hard, because that means that they're not defecating fully, and that could mean that there's stool still inside of their colon, which is just getting backed up and backed up and backed up. It can become so backed up or get so hard that they're not able to expel it anymore, and it can actually cause a rupture in their intestine, which becomes very serious, right? Because then we have feces just all inside their abdominal cavity. So we need to make sure that this person is defecating at least every 1 to 3 days. And if not, then we need to let the nurse know, okay? Because it might mean that they're getting constipated, or that they have a fecal impaction, which is when all that stool is just sitting up there and getting harder and harder. So keep an eye on them. You'll find that in nursing we talk about poop a lot, because poop is a big deal. So here's some of the disorders, just a few of the disorders that are associated with the digestive system. So diarrhea is just very liquidy, watery stool. It is not normal. Okay, it might be normal. Some people say that's normal for them, but it's not considered normal to have diarrhea. It means that they're getting rid of too much water in their stool, and there's a risk of becoming dehydrated, and there's a risk of electrolytes being thrown off. So when we think about our C. diff patients, for example, that's one of our major concerns with them, is that they're going to become dehydrated and that their electrolytes are going to be all out of whack, because diarrhea is often very acidic, okay, and we're losing a lot of potassium and sodium. So it's going to be hard for them to maintain that normal balance. Hemorrhoids are inflamed veins right around the anus usually, and they may be internal or external, so you may see them and you may not. They can be blue in color. They can become very inflamed and painful, and they can even bleed because they're very vascular, so as the person's defecating, it may scrape against that hemorrhoid and cause it to bleed, and they can actually bleed a lot. It can be pretty scary looking sometimes. So definitely, if you see any blood or if you see a very inflamed hemorrhoid, let the nurse know. There are some medications that we can give them to decrease that inflammation, and there are some surgeries that we can do. They can do a hemorrhoidectomy to actually remove that hemorrhoid, but that's a very painful surgery. So we usually use that as a last resort. Constipation means that the person is having a hard time using the bathroom. Okay, so they're having difficulty expelling feces. And there are some things that we can do about that. If they're constipated, we can give them high fiber foods to try to bulk up their stool and make it easier for it to pass. So high fiber foods would be like fruits and vegetables, especially if they have the skin still on them. Whole grains have a lot of high fiber in them. We need to make sure that they're drinking enough, because if not, their stool is going to become very hard, and it's going to be hard for them to get rid of it. And we also need to make sure they're up and walking and moving around, because if you're not moving very much, peristalsis slows down, and that's going to put you at more of a risk of constipation. And constipation is a very uncomfortable feeling. Of course, we can also tell the nurse, this person's constipated. The nurse can use medications. They can use enemas. It's also within the scope of a practice of a CNA to give an enema, which is when we introduce medication into a fluid, usually into the anus, and it mixes around with that stool, and then they expel it. Or they could get a suppository, which is a medication that goes right inside the anus, and it's kind of looks like a wax bullet, and it melts inside the anus, and then the tissue around there absorbs it. So there's some things we can do.